Thank you so much, Chamira, for a very kind introduction. Just before I start, I can see my slides up there. So just want to know if you all can hear me very clearly. Is the audio okay?
Yes, we can hear you. Yes, all perfect.
Thank you. Thank you so much. I think it's a privilege and an honor to be actually participating. I met Dr. Bandara in one of the recent thyroid meetings, and it was wonderful interacting and also understanding how this was a regional meeting, and it had people from all over the world, at least most of Southeast Asia. Without further delving into things, but I would probably take this opportunity to talk about something that we've experienced, and this is sight-threatening thyroid eye disease, one of the most severest forms. Now, this is my only financial disclosure, but there's something else on that slide. There's a QR code, and there's also something that you could use as all you have to do is www.menti.com. It's a website which allows your own smartphone to be used for responses. And there is a code number there which you can use. So it would be nice if you can punch in the responses at some of the questions, pop up there. Thyroid eye disease essentially is actually like any other disease, has got classification based on the severity. And the one that we are trying to project here is the European groups, the UGOGO as we call them. And this is the mild variant. The mild variant in a very simplistic language is one where there is no impact on daily life. The criteria are laid down on the slide, but essentially what it means is most of the time for these patients, all you have to do is just observe conservative therapy. There is also quite a bit of evidence to tend to suggest that at least in selenium deficient areas, giving them selenium oral tablets tends to be of help. The next variant is actually clubbed together. It's not moderate and severe, two different types, but moderate to severe are clubbed together. And there's a reason for that. The reason being that this is the kind of disease where there is a significant impact. And that may be in the form of double vision. It may be because of a significant eyelid retraction, as you can see in the picture, or also excessive proptosis, a combination of any of them. Soft tissue signs, suggestive activity. Now, the point here is that these are the kind of diseases which you would like to possibly modify the course of the disease with the help of therapy, either surgery, disease-modifying therapies. Several will come up in the discussion. Our point of discussion, however, is the most severest form, and this is sight-threatening disease. The types that you encounter are the dysthyroid optic neuropathy, DON as we call it, bilateral, unilateral, recurrent types. You also have corneal breakdown with supraretinal infection, as the bottom left picture, and sometimes recalcitrant glaucoma. All of them are sight-threatening and need intervention. Unfortunately, sometimes there is so severe proptosis that you actually come across an individual like the lady we have, who's got a supplex, who's actually a luxation of the globe, and her own children are scared. And so there's something that needs to be done. Most of the time, that's a very severe manifestation and needs to be dealt with. All of them are sight-threatening. We delve with the corneal breakdown first. We know about the Werner's nose specs. We know about the clinical severity on the UGOGO and how do they talk about. But on the corneal breakdown, essentially what they say is the superficial punctate keratopathy is the most mild form. When they coalesce to form clouding or they form an ulcer, that's the next more severe. And when there is a significant degree of perforation or there is a supraretinal infection, like we often encounter in this part of the world, and there is a risk of perforation, that's the most severe form. Pictorially represented, this is how you see them. On the left is the punctate epithelopathy, but very severe ones are the corneal clouding that you see on the right. It's also not unusual to have people who already have exposure issues along with a supraretinal infection that complicates the problem quite a bit, as you can see in the bottom pictures. The question number one that comes in actually tends to show that what are the factors that you would possibly think is responsible for the ocular surface problems. And when I say ocular surface problems, I want to combine everything into the corneal breakdown that presents as a manifestation. So what are the factors? Do you think this is exposure? Do you think this is because of altered blink dynamics, meibomian gland disease, tear film osmolarity? Can you please punch in? Okay, we've got a response, almost a similar kind of response on all of them. Let's see how it goes. That's good. Okay. So, for the want of time, I wouldn't linger on one slide for a line, but there will be a few more interactive sessions. But what I can clearly see is that most of the times we would think that the structural issues, either in the form of surface exposure or altered blink dynamics, have a big role to play. And fair enough, they are definitely important. But newer literature, especially from Vinay Akula's group, tends to show that a lot of this may also be related to an underlying meibomian gland disease, to tear film osmolarity, to also the cytokines that are secreted in the tear films, and corneal hysteresis and others have seemed to have play a role. So probably on the risk factors, there's quite a bit that needs to be known about corneal breakdown in TD. And that's the essential background I was talking about. So all of them play a role. The sad part is the risk factors related to corneal breakdown. What leads to this is entirely thought to be related to structural, which is in blue of surface exposure and altered blink dynamics. And more work is needed for everything that is outlined or bordered with a red. And that's the kind of work that is needed. Management strategies, this particular lady presented with a punctate epithelopathy on the top picture marked A, and very quickly, unfortunately, progressed to the picture shown with the full-blown microbial keratitis. What we did was orbital decompression in the right eye, in addition to intensive medical therapy. And no eyelid surgery. She declined any further surgery, and that's how. So vision and globe salvage attained by decompression. What I want to highlight, however, is that a lot of times this particular gentleman on the top actually presented with a bilateral affection, like you see, actually a descemotor seal in one eye and a perforation in the right, and needed multimodal therapy, surface, tissue adhesives, intensive medical therapy, eyelid surgery, decompression. But fortunately, with that kind of multimodal therapy, we managed to get good vision and globe salvage. The bottom is the interesting scenario, whereas you have a bilateral affection, but also has a dysthyroid optic neuropathy, the DON, and which you can make out from the CT sections shown on the right. Comes to question 2. This particular young lady had presented with sight-threatening thyroid eye disease, extreme, no other risk factors, but very bad thyroid function, poorly controlled. Now, normally, how would you grade soft tissue signs for clinical activity or visa? Normally, clinical activity score is done for the worst eye based on the classification. So the 3 statements that you have to punch in is, would you do it with the based on the grade, the worst eye? That's the traditional way, left eye with the corneal ulcer. Would you think of doing the clinical activity score based on soft tissue signs in the fellow eye? That's the right eye. Or would you think doing it based on the imaging of the deep orbit? So can you please punch in the responses? I hope it's showing up on the screen on your. Oh, that's good. Right. But so essentially, the point I was trying to highlight here was that the traditional thing of clinical activity score or visa is actually trying to use the worst eye. But I think corneal breakdown on microbial keratitis is a rare scenario where there's a significant confounding factor. So what we tend to do is to actually do it based on the fellow eye and also use the deep orbit, either MRI or something. So that's something is a point to learn, because if you start taking for the microbial keratitis itself, there is a significant amount of soft tissue inflammation. So it tends to not give you the real picture. This is the same lady post surgery. This was again a combination of multimodal therapy and very good outcome. The only disadvantage is when you operate upon hot orbits, you would always tend to get a significant chance of double vision, which can always be corrected. This is the lady at last I wanted to show, very long drawn disease, young lady, very poor function control. And multimodal therapy again, decompression, eyelid surgeries, surface surgeries, and in fact, right eye penetrating keratoplasty and cataract. And she, who would believe with the presentation on the left that she would had actually 20/50 vision in the right eye. So it's a lot of patients of this sight-threatening disease. There are good outcomes. The only thing is it's got to be a multidisciplinary approach with several people playing their part of their bit. The next part is going to this thyroid optic neuropathy is one of the most commonly talked about sight-threatening disease. How do you diagnose them? It's a combination. You obviously depend upon visual acuity, but again, visual acuity alone doesn't help much. Color vision, this is predominantly acquired color deficiency. That's why you have to rely more on blue and yellow color charts, and whatever charts you use for acquired colors, Handy Rant, Rittler, or D15, whichever. Color desaturation is also a very simple test that can be done, but the fading of one of the colors, red colors, is usually helpful. And RAPD, of course, and disc edema. But unfortunately, what happens is only 10% of people who may have DON tend to show up as disc edema. It's usually very late. So the sensitivity of this particular sign is not too much. Imaging has a huge help. We'll delve upon this in a few slides. And visual field and visual evoked potential all have a role to play. I missed a slide. Now, this particular management strategy of DON is always, first line is intravenous methylprednisolone. It remains the mainstay. And there are several regimens talked about, but I think you could follow anything. Essentially, the most commonly is the Yugogo one, which says 1 gram of IVMP for given day, every day for 3 days. It may be prolonged a little longer. Most of this time, because the patient is active, would need further therapy either on the weekly regimen or alternative drugs. Results are quite satisfying. This particular visual field was done only 24th of January 2014 and just 2 days later. And the significant change in the visual field just shows us how much of a response it is to the intravenous methylprednisolone, and very quickly that way. Now, this particular question 3, all CT images belong to thyroid eye disease and all have compressive optic neuropathy except which one? Please punch in the responses. Okay. Any more responses? Okay. Right. So I think, yeah, essentially, I'll show the answer here. It essentially actually is an image E, which is actually a case of stretch optic neuropathy. But we'll delve upon with the help of this slide. Now, on the top panel is something which is very commonly talked about: apical crowding, effacement of the perineural fat, and from the coronal section on the right top is what shows this very well. But I think the little less spoken about or reported, but they have been reported, but less spoken images for DON are actually on the left, which is the fat prolapse along the superior orbital fissure. You also have a proximal optic nerve sheath swelling because of the CSF getting filled in that space. But on the right is a very typical and odd man out, which is essentially a fat kind of a predominant disease, and there is thinned out muscles, and there is a huge proptosis, and essentially there is a straightening of the nerve. The other thing that you need to look out for is also a tenting of the posterior pole of the globe. The important thing to remember is most of these stretch optic neuropathies do not respond to IVMP, and you have to think about a surgical management. So that's the reason to delineate them from the rest of the compressive optic neuropathies. And I think we come to the next question. What are the known risk factors of dysthyroid optic neuropathy? All of them are except. So there's just one out of them which is not. Please try to punch in. Okay. I see the responses. So that's good. So a lot of inputs into diabetes and quite a lot into diabetes, systemic thyroid function, radioiodine, and all of that. So that's very, very interesting. So, that's excellent. So thank you for bunching the responses, and pretty much along the right lines. Just wanted to show that only one thing that is important is actually male gender. Thyroid eye disease is essentially a disease of the female gender. I mean, the thyroid dysfunction is commonly seen in female gender. For some reason, males have a higher risk of dysthyroid optic neuropathy. So that's the only one which is not. So good to see that response, and it's pretty much along favorable lines of what we know. This is our own study of 201 patients, which tended to show that both smoking and diabetes have a significant risk, that double the risk of dysthyroid optic neuropathy. And there are major risk factors that need to be thought about. In our part of the world, we might forget to ask, most of the times our protocol, but you would definitely ask that, are you diabetic? Because it tends to change the way you could possibly manage this disease. This particular individual, a middle-aged individual during COVID times, difficult travel restrictions, unfortunately had a DON which was refractory to IVMP, 7.5 grams already given before presenting to us. He also had rituximab, underwent finally surgery, no other respite, and good visual acuity. I developed a small complication of orbital compartment syndrome, which was again fortunately managed in a remote location with the help of an ophthalmologist. Finally, the picture on the right shows that he had gained good vision. So 24 months from the onset of the disease was when the decompression was done. Just to show another CT scan picture, essentially showing that instead of a triangle or a pyramidal shape, you are expanding the posterior orbit, and that's what you're trying to do. And essentially, that's the key thing that is important to remember. I had one particular, I don't know whether this one plays, but essentially in our own experience, we tend to do most of the time endoscopic decompression. And I just am a little worried whether this would play or not. In the interest of time, I think I would move on and to talk about, so the change in endoscopic decompression is so dramatic that this elderly individual had a 20/80, 20/60 vision, only demo plates in the color vision. And look at the change on the very first day after surgery, endoscopic, he had 20/40, 20, and there was a change in the color vision. And 1 week after surgery, he's reading 21 out of the 23 plates. So quite remarkable results, and the morbidity related to endoscopic decompression medial wall is much less. This is my last case that I want to share. Glaucoma is a rare thing. We need to understand that checking intraocular pressure is quite a challenge in TED. There is a tethering of the muscle. The position has to be relaxed quite a bit. You need to take the position, intraocular pressure, both in looking down position and a straight position. And sometimes that itself may show the pressures are high. So what is ocular hypertension? What is glaucoma needs to be thought about, but quite a few of them have high pressures that need to be thought about. Now, this particular individual had high pressures, had already undergone a right glaucoma filtration surgery by the time he presented to us. And we can also see the bad strabismus that he had. This particular picture tends to tell us the kind of result. We did a right eye decompression followed by a left eye decompression. But when we did the left eye decompression, we also did the muscle surgery. And that caused a little bit of the lower eyelid retraction that is there in the right eye. But he's straight now and very happy. His pressures are good control. He still is on 1 or 2 AGMs, but pretty better than what he was. So a lot of thought goes into it. That's his CT scans before and after. I think finally, to summarize, essentially, sight-threatening thyroid disease, it needs expeditious management and most of the time, extremely urgent multidisciplinary care. We talked about the need for multidisciplinary care in the need of corneal breakdown, the various manifestations, but generally can have good vision and globe salvage. This thyroid optic neuropathy is we know more about risk factors. So moreover, whenever there are more risk factors, one need to be extremely aggressive in management. And again, good results reported from that. Recalcitrant glaucoma and globe luxation is only about surgery, and that's decompression. I think that's the end of it all. If there are any further questions, comments, you can always send to my email. I'll look forward to comments. Thank you.